The issue with this talk is, robotics and laterals, there's not much on it, okay? So robotics in general is fairly new, and it's been mostly used for screw placement, right? So how does that impact a lateral operation? It doesn't impact it very much. So, there's not much meat to this talk, although I think there will be in the future. And so I'm going to sort of give a little bit a generalized talk about technology and how robots fit into it, and I think where we're going to go with it in the near term. So this is interesting. I don't know if anyone's actually ever seen this type of curve. It comes from the advertising business world. It's Gartner Hype Curve. And it's used actually fairly frequently, from what I understand. And I thought it was an interesting curve because it kind of mirrors spine technology or techniques quite a bit. So this is a Gartner Hype Curve, right? And it covers 5 different phases. And so if you, I don't have a pointer, but if you read the bottom line above time, there's 5 different phases. One is technology trigger, peak of inflated expectations, trough of disillusionment, slope of alignment, and plateau of productivity. And this is how spine is actually for technology, because if you actually look, if you go to spine conferences in general, there's always themes where that's all people talk about. So I don't know how old you guys are, but like 10 or 15 years ago, everybody just talked about arthroplasty. Lumbar or cervical arthroplasty. You could not go to a meeting with an arthroplasty talk. 90% of our meetings are arthroplasty. We had societies like this, it's called SAS, Spinal Arthroplasty Society, because everybody thought it was going to be the next big thing. It was going to take over spine. It was the next leap forward for mankind. And so it really actually didn't happen. But it follows this curve quite closely. Like you have the technological trigger, then you have all this hype behind it, marketing, it's going to do everything, solve back pain, and we're not fusing patients, so we don't have to worry about it. So we might as well just implant them on everybody, right? So you got this this hype curve going all the way to the ceiling in terms of what you expect, right? Then they were starting to be implanted in this country, and they found it's no better than the outcomes were no better than a bad back fusion operation, actually. And so that's why lumbar is not even reimbursed in this country. I mean, cervical has found a place, but that's where you get your trough of disillusionment. Because once the technology makes it to the mass, consumers, us, and people start to use it, and it doesn't work as expected, or you don't see the outcomes, people go, oh, this is like false advertising. I'm not going to use it anymore. It's piece of junk. And we see that all the time in spine. And so what can happen is it may exit the market, or you may find that it's not as good as promoted, but there's some value into it. And then as future iterations get produced, it finds a place in the market and it gets accepted. And I think cervical arthroplasty is sort of like that, right? So if you look at these curves can go either way. And I was trying to think of different implants, and some start to gain value, and I think spinal navigation is one of them. Okay, like I said, cranial navigation is standard care. 100% of surgeries use spinal navigation. Cranial navigation. Spine hasn't come to that point, but it is growing. So. There was a census about how many surgeons use navigation, I think about a decade ago, and it was only 11%, and these are just surveys, so not perfect, right? So very small market, right? This was recently redone, I think 3 or 4 years ago, and it was about 30%. So it's growing. So spinal navigation is finding its place, and I think it's because with multiple iterations, they've refined the problems with navigation, and it's found a place. It has some value, and I just kind of went over a talk, so I'm biased, by the way, if you didn't know. But, so it's found a place, right? But there are other technology. I don't know how many people remember X-stop at all. Spinous decompression. So that I think I read an article. It was like it had the biggest hype. So it went to the roof in terms of what you would expect. Then it got out and people were implanting. It didn't work. It wasn't durable. And then it exited the market like soon after, right? After Medtronic bought it for $1 billion or something. But essentially, it went away. Right, so it met no expectation. They found no value in it. So it's one of these things where I could name so many things that were on this X-stop curve when it comes to spine technology, right? So the question is, where's a robot going to fit into that? And I'm going to argue it's not going to just go away, honestly. I think it'll find its place. But this is an interesting curve because I think you can apply it to a lot of things in spine. So robots, what should they do? Well, we typically think of robots as machines that could perform a task autonomously, efficiently, reliably, right? No errors, right? I always assume a machine's not going to make a human error. Right? That's what I think about a robot. And I have a very simple diagram here of a robot folding clothing. I expect it to fold clothing perfectly every time. We'll have a stack of like folded clothes, right? But that's really not what a spinal robot does, right? A spinal robot, it's not autonomous. We can't have it autonomous. The FDA won't approve it, okay? They just don't trust it. And they're just essentially assistive devices right now that really impact a relatively small portion of the procedure, right? So, some people have named them cobots, meaning they're just kind of helping you. They're essentially a role player, and if you ask me, they're kind of a bit player in your procedure, right? It's useful for putting screws in, right? So if you're already navigating, the impact of a robot to standard navigation is probably like this. If you're not navigating using fluoroscopy right now, you're going to see maybe a bigger impact because of the radiation exposure issues, maybe more accurate. It's less fatiguing because all you have to do is kind of just push the drill down. I'll get to that. So it's pretty straightforward. But the impact is not high right now. But this is remember, this is essentially we're in the first generation of robotic technology. So right now, all robots are optimized for really is percutaneous screw placement. I say percutaneous because if you try to use a robot with an open incision, it doesn't work so well because you make your screw plans, right, and you try to medialize the screw because that just seems the trajectory you want, but with an open incision, often you can't get enough of a wide incision with your standard open operation to get the screw plans you want. So the robot arm won't even position itself correctly. So it's really optimized for percutaneous screw placement and cortical-based screws. You could use it for a traditional open operation, but you'll find that you're going to make your incision a lot larger, or you're going to have to make stab incisions to get the trajectory, or you change your screw plan so it's more straight in. Some robots now are navigation capable, and I think this is the important point because when you think about it, navigation is just a more advanced, a robot is a more advanced navigation system. In fact, I would call it a robotic navigation platform, and that's how you should think about a robot, okay? And that's what it's going to be, at least in the near future, for any iteration on the robotic platform, it'll emphasize the navigation component of it. And this is, I think, where it's going to provide value because it'll impact every aspect of the procedure, not just the screw placement. Because if all it does is screw placement, it's really going to just be a role player. And I'm not sure it's worth $1 million investment. So I'm going to specifically talk about laterals, and I'm going to get to like some of the future aspects of what's going to happen, probably this year or next year. So I think it's always important to look at the literature to see what's out there. And this was a relatively recent literature review looking at robots. And this was published in 2018. They had 32 studies. And they looked at 4 main endpoints. Screw implant accuracy, that's kind of low-hanging fruit. Radiation exposure, operative efficiency, and time savings, as well as length of stay. So really, most of the studies had to do with the first 2 categories. There's very few studies on those other endpoints, so really so few that you really can't make any conclusions. So I'm not going to really even go over it, and I'm not going to bore you with a complete literature review. Basically, if you look at screw implant accuracy, this will highlight everything that was mentioned. It's highly accurate, greater than 90% accuracy, many of them in the high 90s, okay? When it came to radiation exposure, the majority of studies, or 13 of them, showed decrease in radiation exposure. What I found surprising, though, it wasn't 100%. They had actually 3 studies that were comparative studies where freehand had less radiation exposure than the robot. And when you look at the studies, it made sense. These surgeons were very comfortable using freehand approach. You don't have to take too many images using freehand, right? Fluoroscopic views. When it came to robot, they were uncomfortable with the robot and they didn't trust it. So they took a bunch of pictures to make sure the robot was doing what it should. So they kind of artificially increased the radiation exposure. But in general, the robot will decrease your radiation exposure, particularly with MIS procedures. So what about the robotic-assisted laterals, right? So presently, it really is at the elementary stage. The only role is screw placement, and the biggest impact is in single-position surgery, right? And compared to traditional fluoroscopy, and actually Alex showed a very good example of fluoroscopic-based laterals, and he's experienced, right? If you're not experienced in it, you'll fiddle quite a bit just trying to get the screws in. And you can shoot a lot of fluoroscopic images doing it. So I think this is one of the biggest benefits, actually, particularly with the single position approach, because the downside screws are actually hard to do. I mean, Alex made it actually look pretty easy, but if you try to do it, then you guys will have an opportunity. It's actually a bit more challenging than what he showed. And if you look at the literature behind single position surgery with the robot, there's only one article. And, I have to say that you should look at this article with a little bit of grain of salt, and it's because one of the authors was from industry, and I just point that out, just try to make it unbiased, but just so you guys know. So you look at this is a single study, single surgeon, 55 patients with 328 screws placed, which sounds like a lot, and this is the single position robotic surgery that's being done here, okay? And the patient population is what you would expect from a DGEM population, and the most common operated levels were what you would expect, 4 or 5, L3, 4 or 5, with laterals, not so much S1 obviously because it's lateral surgery. And levels, so numbers of levels treated. So 2 levels means 1 disc level. So that just means 2 vertebral segments. So most of the surgeries were between 1 and 3 levels. It's exactly what you would expect. And what this study found was so they had 342 screws placed totally. However, 14 of the screws were placed manually, and it doesn't state why. My assumption is the robotic screw plans or the arm didn't work for whatever reason, so they were placed manually. Okay, it really doesn't explain why it wasn't placed with the robot. All right. Of the 328 robotic-assisted screws that were placed, 7 were repositioned. Unclear why, but I suspect they were just not in the correct location, so accuracy was off. Okay, so the author of this study suggested the accuracy was 98%, and I might argue it's less than that because I don't know what happened with these 4 screws, right? In the top portion. And the other thing is how they determine accuracy was by X-rays. I can tell you X-rays compared to CT. If your idea of accuracy is a screw completely contained with a pedicle, is not as sensitive. So I would be willing to bet the accuracy is going to be a little lower than 90% if it was CT-based, okay? Having said that, there was no complications. We know we don't have to be perfect for a screw to be useful. So there's one other study looking at laterals and robotic screw placements, and this was just published. It was Open Journal, Orthopedic Surgery. It's out of China, but it was really a 2-stage operation. They did a lateral and they repositioned prone. And this is just a picture of it. But that's all there is in the literature when it comes to robotic surgery. And this data is not surprising with the decreased blood loss over time because their comparison group was freehand open, so they're going to have an open exposure, so obviously the blood loss is going to be higher. But the accuracy was higher. So the current impact of the spinal robot and laterals is very limited. And here's an example from my own, one of my own cases, because I've been playing around with single position with a robot. And 66-year-old woman with back and leg pain, failed conservative management, high-grade stenosis, something we see all the time, okay? And how I position the patient. And this is for single position surgery, so make sure the back is well exposed, and it's as Alex was saying, was closer to the edge of the bed, but you don't want to be too close. And the lateral is straightforward. I navigated it. Again, this is not using a robot, just standard navigation. So I started with the interbody cage placement first. Again, I don't like to expose myself to radiation, and it's very straightforward with our workflow now. And so then after this is just showing the navigation pointer as I'm getting the exposure. Again, I'm not using fluoroscopy here. I'm just advancing. In this case, it's at 4.5. The iliac crest was in the way, so I took a slightly oblique approach. That's a nice thing with navigation. I take whatever approach is easy. I prefer transpsoas, but if not, I just come a little oblique. And with navigation, it's easy to change your plan. So I just take whatever is the most expedient approach into the disc space here. And so this is for the initial dilator, and then this is a navigator trial. Then the cage goes in. I just tilt it orthogonally right before the cage is fully seated. And this is after the cage is in. This is how I've been using a robotic technology. Is you have to get another image acquisition, and I do intraoperative image acquisition for just because we've changed a few things. And after the image is acquired, you could make your screw plans. It's very straightforward to make your screw plans, right? So if you haven't seen a robot, you can change your diameter screw, the length of the screw. This is very easy to change, your orientation. It really literally takes a minute. And the nice thing here is, the robot just positions itself into place. You make a paramedian incision. And, I typically don't scrub for this, or if I do, I'm just standing there with my arms crossed. I'm a little out of field of view. That's one of our residents doing it because it's very straightforward. It's a two-step procedure. They drill the tract and they follow it with a screw. Okay, it's much easier. There's no fiddlesome factor in terms of, having a fluoro in there, as long as you trust the robot. It's very straightforward. It's actually a fairly quick process. And this is just with the rods in, past the rods. And here's just the post-op imaging. So, indirect decompression with the disc height restoration, reduction of the spondy. So, that's right now. So what's going to happen in the near future? I think within the next year or two, what's going to come out is the advancements or the refinement of the existing robotic technology, where it's going to start to impact other aspects of the procedure. And this is mostly based on the navigation capability. So what I'm going to show you is what's being done in a cadaver right now, but very soon it'll be available. And this is where I think the robots can start to show some value. Right? So right now you could argue just putting screws in is not that valuable. I'm going to pay $1 million to just put screws in a little bit better. Right? So I think with this new iteration, again, this is just a near future, right? 5 years from now, this is going to be much better. We're able to plan cage placements a lot better. And what's the value in that? Well, I think if we care about segmental alignment, how we place a cage sometimes is important, or the size of the cage, if it's an expandable cage. So precise planning of your operation and actually having the implant go where you want to is an important factor. I think everybody here has probably done interbody cages, right? Whether it's TLIF or laterals, and sometimes the cage just doesn't go where you want it to, and you just go, okay, whatever. It's like if you're doing a TLIF, it may not be in the middle; it's off to the side or it's too far in, right? So it's not optimally placed. But with pre-planning using the system, that no longer becomes an issue. So this is an example of how the workflow would go with a robotic-assisted lateral with beyond just screw placement. So the first stage is you put your screws in with the robotic technology, which I just showed you, right? And this is showing both cages are in. Okay. Then after that, this robotic navigation platform now will allow you to actually place a retractor like I showed you before. It's going to be part of the system. Right now I'm using two different systems, but it's an integrated robotic system where you just make the flank incision based on navigation, utilizing a robotic platform. You sequentially dilate, put the retractor down. The retractor, theoretically can be navigated. So you'll see a projection on the screen of where the navigator is pointing to in relation to the disc, as well as the surrounding anatomy. That's whether your psoas muscle, your vascular anatomy. And so everything's in view and everything's imaged, right? Your instruments. And that allow you to, basically, with MIS, again, your visual cues are limited. But with this, you're basically able to see everything. And I think precisely do the operation to what you would plan. And this is just some examples of this. This is a pre-planning of a lateral cage on a robotics platform, right? You could look at the cage size. Here's the width of the cage, the height, length. You can look, does it fill the disc space adequately? And then you could go to plan. So this is intra-op, putting the cage in exactly to your plan. So this is a near-term advance that will be out pretty soon. But you start to see the robotic technology start to impact every aspect of the procedure. Now, I'm aware of other aspects like disc pace preparation. Right now it's pretty cumbersome. But if you imagine with highly advanced navigation, you could demarcate your disc space and you could have an instrument based on the boundaries of the end plates pretty rapidly help you do a discectomy, right? And I think other companies want to integrate automatic rod bending into the technology of the robot, because once you screw plans are used and the screws are put down, the robotic will have a three-dimensional image of where the screw heads are. It could contour a rod for you as well. So there are a lot of aspects that are coming down the line. That's why I think the robot eventually will have a place. Right now, it's very elementary, right? But when you look at the resources being spent by many companies trying to advance this, I think it's going to be a benefit to surgeons. And obviously, we'll make the surgery, I think, more efficient and hopefully more consistent and reliable. And so I come back to this Gardner curve, and I think with future iterations, and I just showed you sort of the second iteration of the robotic navigation platform, what's going to occur. It'll advance it a little. With the next iteration, it'll keep advancing. And it'll mirror spinal navigation, where it's become very facile in value. So I think the robot technology is going to have an upward tick. At least that's my impression of things. So the summary is essentially what I summarized. So I'd be happy to take any questions.